Good afternoon, everyone. Welcome to this webinar. We will wait a couple of minutes to allow all the people to join. Okay, so we will start in 1 minute. Perfect. I think that I can start. In the meantime, other people are joining. So good afternoon, everyone, again. I will start briefly by introducing myself. I'm Laura Girardi. I'm the head of the scientific support department for our genetic services at Vitrolife Group. I have a team of genetic counselors and scientific advisors distributed in the region called EMEA, so Europe, Middle East, India, and Africa. And we are available to support our collaborating clinics, our partner doctors, and of course, our patients. And today it's my pleasure to moderate this scientific webinar with the title ERA, a proven solution for RIF. So very briefly, in this webinar, we will review the results of the recent research and randomized control trials in guided personalized embryo transfer, and we will also discuss challenges with previous publications. I just want to remind you that this is volume 1 of our three-part series webinar we will be conducting throughout the next 2 months. So please make sure to register for the other upcoming volumes. And in details, in volume 2, we will explore the unmatched precision of ERA for further maximize patient results. We will have the opportunity to review the science and continued evolution of the ERA to deliver the best endometrial receptivity test in the market. And in volume 3, we will have leveraging the comprehensive support and expertise behind ERA to optimize outcomes. And in the last webinar, we will have the opportunity to highlight the clinical support team behind the ERA, including endometrial specialists, scientific advisors, and genetic counselor, and not only providing support to clinicians using the test, but as I was saying, also to patients. In this webinar, we will have the Q&A at the end, but the attendees can type their questions even during the presentation, so throughout the presentation. So make sure to write down all your questions that we will get at the end. And in case we will not have time to cover all the questions, we will reply one-to-one after the webinar. So after this introduction, now it's my pleasure to introduce today's speaker, my colleague, Dr. Tiffany Stankiewicz. Tiffany earned her graduate degree in animal bioscience from the Pennsylvania State University and a PhD in genetics from University of Kent, where her thesis centered on optimizing IVF outcomes by controlling for both embryonic aneuploidy and endometrial receptivity using genetic testing. Tiffany has over 15 years of clinical laboratory experience as a fully trained embryologist and is certified by the American Board of Bioanalysts. in both embryology and andrology. Tiffany joined iGenomics in 2016, and today she serves as the Global Endometrium Product Director for iGenomics. So without further delay, Tiffany, whenever you want, the stage is yours. Thank you.
Thank you, Laura, for the introduction. And thank you for joining us today to talk about ERA, a proven solution for RIF. So I want to start out this presentation with a brief introduction about implantation itself. We know that implantation is a significant rate-limiting step in both human reproduction and IVF. So what is the equation for success? Well, at the very least, it's an optimal embryo plus an optimal endometrium. Looking at the ESHRA good practice recommendations on recurrent implantation failure that was published back in 2023, they define RIF depending upon whether the embryos are of known euploid status or of unknown euploidy. Looking at if the embryo transfers were with euploid embryos following PGT, they define RIF as transfer of 2 euploid embryos, regardless of the age of the woman. However, when we look at transfers of unknown euploidy, the definition changes a bit, with transfer of 3 embryos in women less than 35 years old, transfer of 4 embryos in women between 35 to 39 years old, and transfer of 6 or more embryos in women greater than 40 years. Now, they mention the causes are multiple factors, such as embryonic, so chromosomal aneuploidy being one that we mainly think of, lifestyle factors such as obesity, hereditary such as thrombophilias, or endometrial such as receptivity. Now, looking at recurrent implantation failure a little bit deeper, we know that RIF affects approximately 10% of couples undergoing IVF. Now, this is a somewhat frightening statistic that after the 3rd failed cycle, reports up to 22 to 50% dropout rates have been seen, with increasing tendency with each consecutive cycle. Now, patients we know are desperate to do something different and to effectively address and overcome their implantation failures. They're looking for a solution. Now, referring back to the ESHRA good practice recommendations for recurrent implantation failure, they do recommend investigations for RIF, and this includes investigating both male and female partners. So examples of this include recommend reviewing lifestyle factors in both partners. Reassessment of endometrial thickness is also recommended. You can consider karyotyping of both partners to confirm absence of chromosomal abnormalities, such as maybe an unknown translocation. Endometrial functioning tests such as receptivity or the ERA test can also be considered. Or you can consider analysis for chronic endometritis using tests such as EMMA and ALICE. So today, we're going to be focusing on endometrial function testing for receptivity. And that leads me to the ERA. So what is ERA or ERA? So first introduced in 2011, ERA, which stands for endometrial receptivity analysis, is the world's first molecular assay used to determine each woman's unique personalized embryo transfer timing, therefore synchronizing the embryo transfer with the individualized window of implantation. Looking back onto earlier studies that we published from our group, the first being in 2011, with the objective to create a genomic tool composed of a customized microarray and a bioinformatic predictor for endometrial dating. And then in just 2 short years from there, we demonstrated the clinical value of the endometrial receptivity test in patients with repeated implantation failure, in which we saw an increased percentage of window of implantation displacement in patients with RIF compared to the control group without a history of recurrent implantation failure. Furthermore, rescue of non-receptive patients with a personalized embryo transfer based on their own personalized window of implantation yield similar clinical outcome rates to those of the good prognosis patient group. So who should use ERA? Well, if you refer to our resources on our website, including our endometrio manual, you will see that we indicate ERA for patients with recurrent implantation failure. Now, I want to dive into the newer research supporting this indication, as ERA is a proven solution for RIF. And to start out, I want to define what does it mean to be a proven solution. And as many of us in the field, we refer to randomized controlled trials, which are the gold standard in evaluating the effects of treatment. However, we need to be very specific in our definition to include that in order for these RCTs to be clinically meaningful, results must be relevant to specific patient populations in specific settings. Now, keep this in mind as we go through the RCTs that have been conducted with ERA. So to this date, there have been 3 randomized controlled trials on ERA. The first one by our group in 2020 is by Simone et al. The second one by the Shady Grove Fertility Group in the US, Doyle et al. In 2022. And most recently, Barbacazzi, which was published in 2024. Now, when we look at these, we have to consider who were the specific patient populations studied in these groups. Well, looking at Simone et al. 2020, these were good prognosis patients without a history of recurrent implantation failure. The point here is that in prospective trials prior to conducting this RCT, we had clearly seen the benefit in recurrent implantation failure patients, and we wanted to explore the possibility of patients outside of this indicated population. So for this reason, good prognosis patients without RIF were included. Now, the conclusions here was that despite 50% of patients dropping out compared to the 30% initially planned, the per protocol analysis demonstrated statistically significant improvement in pregnancy, implantation, and cumulative live birth rates in the personalized embryo transfer with ERA versus both the frozen embryo transfer without ERA and the fresh embryo transfer arm, of course, without ERA. Now, just 2 years following the date of this published paper, Doyle et al. Published their randomized controlled trial. It was similar where they were comparing ERA to no ERA. However, they did include testing for embryo aneuploidy with PGTA. And what they found was that there were similar outcomes between those patients who underwent the ERA test versus those who did not. And finally, with Barbacazzi et al. 2024, this was in the indicated population of recurrent implantation failure. Similar to Doyle et al., in this study, they only transferred embryos of known euploidy following PGTA. And we'll go into the conclusions of this study in more detail the following slides. However, the point that I want to make here is that we have to look at the specific patient population in order to understand if ERA is a solution for RIF. Now, again, Simone et al. Was in good prognosis patients, not the indicated RIF population. Same for Doyle et al. In 2022. And it's only Barbacazzi et al. Which included indicated RIF population in their study design. So when we consider the 3 randomized controlled trials for ERA, we have to consider Barbacazzi et al., as this is the only one in RIF patients. Now, looking deeper into Barbacazzi et al. RCT, the objective here was to improve ART outcomes with personalized embryo transfer, or PET, according to the ERA test in advanced stage patients with challenging reproductive histories, and RIF by utilizing donor oocytes with PGTA for embryo testing. Just to show the study design in a more clear format, there were actually 3 groups involved in the study. The study group were patients 35 to 45 years old, again using donor egg and PGTA with ERA transfer. The second group was control group 1. So we had the same age as the study group, so AMA patients 35 to 45 years old. They too used donor eggs and PGTA, but no ERA was performed. And then finally, control group 2. So these were patients younger than 35 years old using autologous eggs, but using PGTA and, like the study group, also ERA. The study duration was from 2020 to 2023 and ultimately included 320 patients with recurrent implantation failure. Now, looking at the results, we first compare study group to control group 1. So remember that the patients were all advanced maternal age in both of these groups. They both used donor eggs, and they both used PGTA to screen for aneuploidy. The only difference was that study group underwent the ERA test and underwent a personalized embryo transfer according to where their window of implantation existed. Now we look at the clinical outcome here, and we see that pregnancy rate, implantation rate, and live birth rate were all statistically higher in the group that also used ERA versus the group that used PGTA alone. So in the ERA group, we had a pregnancy rate of 77.9% versus 57.6%. Implantation 54.1% versus 35.5%, and live birth rate 71.3% versus 39.4%. In a second comparison, we look at, So just to summarize these results, the study group, we yield live birth rates almost doubled of the control group. Now into the second comparison. So here, the authors of the study, they compared the study group versus control group 2. So keep in mind the study group, again, were your AMA patients versus control group 1, which were your younger patients less than 35. However, both patient groups had PGTA plus ERA and a personalized embryo transfer. And what we saw was that there were similar clinical outcome rates between these two groups. So for example, pregnancy rate was 77.9% in the study group versus 77.3% in the control group. And we look at live birth rate, 71.3% versus 65.9%. So to summarize this comparison, we see that ERA mitigated the effects of endometrial aging on reproductive outcomes for those patients in the advanced maternal age group. So taking all of these results together, we can do a comparison, and we see that the arms that used ERA plus PGTA are in the blue, and then the arm that used PGTA only is signified by the orange color. So a significant improvement when ERA is added to PGTA is seen both for advanced maternal age patients and also younger patients. Conclusions provided by the authors was that personalized embryo transfer guided by ERA significantly improves pregnancy, implantation, and live birth rates in patients with RIF, including those of advanced maternal age. Furthermore, with no significant difference in clinical rates between the study group and control group 2, using ERA with euploid embryo transfer overcomes poor reproductive outcomes associated with advanced maternal age, normalizing them to those achieved by younger patients. So key points to take away here is 1, randomized controlled trials are the gold standard in evaluating the effects of treatments. However, to be clinically meaningful, results must be relevant to specific patient populations in specific settings. Number 2, RIF is the indicated population for ERA. Furthermore, Barbacazzi et al. Is the only RCT conducted in the indicated population for RIF using ERA. And then lastly, ERA is the only endometrial receptivity test backed by an RCT. Now, I do want to share a very recent publication. This just was published back in May of this year. It was a paper from our group, and it was entitled Clinical Outcomes Following Endometrial Receptivity Assessment Guided Personalized Euploid Embryo Transfer in Patients with Previous Implantation Failures. And here we had a similar study design to the one seen in the Barbacazzi et al. RCT. We had a group that used PGTA plus ERA and a group that simply used PGTA alone and transferred at the standard time in an FET. Now, what we saw was a significantly higher implantation rate, pregnancy rate, ongoing pregnancy rate, and live birth rate in the PGTA plus ERA arm versus PGTA alone. So we see that ERA increased the odds of ongoing pregnancy by nearly threefold. Now, I bring up this because what was interesting is that basically the findings of the Barbacazzi et al. RCT were found to be reproducible with this recent publication that came out in 2025. Again, we had similar study groups, PGTA alone versus PGTA plus ERA. And then furthermore, both studies nearly doubled the live birth rates when ERA is added to PGTA transfers versus when PGTA is just performed at the standard transfer time. Now, beyond these two papers that I shared here, I want to mention that since the development of ERA in 2011, the test has been extensively studied. We have over 50 clinical trials, most of them being independent of iGenomics and VitroLife Group, so trials that were conducted by users in clinics using ERA. Supporting its role in personalized embryo transfer. And these are particularly for patients with recurrent implantation failure. And I invite you to access the trials and the papers that have been published about ERA. You can actually visit our ERA Insight Hub. I'll provide more information about that at the end, but you can access our full publication list, and then you just click on each publication and it will take you to the link on PubMed to review those. But what about publications questioning the clinical utility of ERA? I get this question quite a bit. And I'd like to share with you what I consider probably the 5 most controversial results when it comes to ERA. And this was the Tran et al. Paper in 2022, Casalino et al. By the EVRMA group in 2022, Arian et al., which was a meta-analysis from Boston IVF in the US, Doyle et al., which again, we reviewed earlier. It was the RCT from the Shady Grove Fertility Group. And then finally, Richter and Richter, which was published in Human Reproduction back in 2023. And it was an opinion piece by a statistician, or I guess 2 statisticians. Now, what we need to consider here is that, well, first of all, the Tran et al. Paper has been retracted from Fertility and Sterility. That was as of October of 2024. Casalino et al. Was in good prognosis patients, not the indicated RIF. On top of that, there were some other issues, which you can read in the comments. Arian et al. Also conducted in good prognosis patients, not the indicated RIF population. Furthermore, this meta-analysis, it claimed to be looking at ERA only, but one of the studies included in their review was from ER-Peak, which is obviously not the ERA test. So that affected some of the data in the review there. The Doyle et al. RCT, again, good prognosis patients, not the indicated RIF population. And then finally, Richter and Richter. So Richter and Richter was just a reanalysis of the Doyle et al. RCT results. So again, we come back to that this was based on good prognosis patients, not the indicated RIF. Furthermore, there were some misunderstandings of how the test is actually performed in Richter and Richter. And lastly, they had referenced the Tran et al. In their analysis, which obviously we know was subsequently retracted. Now, looking at the Tran et al. In a bit more detail, you can actually find a full retraction notice again on our ERA Insight Hub. But this was a meta-analysis published in July 2022 in Fertility and Sterility. The conclusions claim that ERA showed no significant improvement in IVF outcomes except for live birth for patients undergoing their first IVF cycle. And what happened was that the ASRM Publication Committee and Editor-in-Chief of Fertility and Sterility officially retracted this publication on October 30th, 2024, following the discovery of significant errors. And these errors included, they triplicated results in the analysis. So the authors stated that there were 4 RCTs reviewed. However, 3 of the 4 RCTs were the same exact study. They incorrectly stated that they analyzed patients with ERA versus patients without ERA. And this is a very important concept to keep in mind. The actual comparison here was ERA receptive patients versus ERA non-receptive patients. This meant that both groups still underwent a PET according to their personalized window of implantation. Just because a patient is receptive at the standard time of transfer, so i.e. 120 hours of progesterone exposure, does not mean she's not undergoing an ERA personalized embryo transfer. She's still undergoing a personalized embryo transfer because you're transferring according to where her personalized window of implantation is, even if it's not displaced. So this is a big misconception that we get in a lot of the discussions of some of these controversial results. It's just a misunderstanding of what a personalized embryo transfer actually is. So that lends to bias in their analysis. And then there was other issues, such as it is unclear how the studies were selected for this meta-analysis. And then the authors stated they didn't use abstracts, but indeed abstracts were used in their analysis. So if you do go into fertility and sterility, you'll see a big retraction on that paper. Now, ensuring optimal results with ERA. This is where I want to introduce you to our ERA Insight Hub. So you'll find many resources here. You'll find information about the Barbacazzi et al. RCT. We have a very nice infographic that summarizes the results of that paper. You'll find expert interviews on their experience with the ERA. You'll also get tips from our scientific advisors around the world. So we have quite an extensive team of scientific advisors and endometrial specialists. We even have physicians on staff and clinical microbiologists if you're doing Emma and Alice. So we're very well equipped to guide you and your patients how to really optimize results when using ERA. Speaking of patients, we also do offer endometrio pre and post testing webinars for patients. So they can sign up for there on the ERA Insight Hub. And we just provide some news about new publications or perhaps new webinars that are coming up. We have clinical tools too, such as our PET calculator. This is extremely handy. It lets you type in the patient's cycle information and timing, and it will compute when to start progesterone or when to do transfer based upon the information you put in there, just to double check we're getting the best results. So I want to wrap this up so we have time for our Q&A today. The conclusions here was that successful implantation is a rate-limiting step to successful pregnancy in both human reproduction IVF, and it largely hinges on an optimal embryo and an optimal endometrium. So again, optimal endometrium can mean many things. Receptivity is one, microbiome is another one. Recurrent implantation failure, or RIF, affects about 10% of the population, and patients affected by RIF are prone to drop out of IVF treatment. These patients are eager to address the cause of their implantation failure. And again, I had said at the beginning that this was a bit of frightening statistic that reports up to 50% of patients drop out, especially when it could be as simple as adjusting their timing of transfer, in which we have many case reports showing that maybe a patient transferred just 24 hours later, or 12 hours later, or 12 hours earlier, and had a successful implantation and live birth. ESHRA good practice recommendations indicate that endometrial functioning testing, such as ERA, can be considered for cases of recurrent implantation failure. The ERA test was the first commercially available test addressing RIF of endometrial origin. RCTs are the gold standard in evaluating the effects of treatment, but again, to be clinically meaningful, results must be relevant to specific patient populations. The only RCT in RIF patients that test endometrial receptivity, specifically ERA, demonstrated significantly better reproductive outcomes for patients who used ERA plus PGTA versus those who used PGTA alone. Furthermore, advanced maternal age RIF patients had similar clinical outcomes to younger patients also suffering from RIF, so hence mitigating the effects of endometrial aging that they're experiencing. ERA is the only commercially available endometrial receptivity test backed by a randomized controlled trial. And although controversial results have been published about ERA, it's important and imperative to thoroughly comprehend the study design and the findings, as most of these studies were conducted not in the indicated population for ERA and possess significant errors leading to retraction in some cases. And then finally, ensuring proper protocol compliance is necessary to achieve superior clinical outcomes for RIF patients. Again, our ERA Insight Hub was created just to do this. We want to make sure that we're delivering the best to clinicians and patients, and you have full access to the expertise that we have within the VitraLife group. In fact, you'll see on the next slide, that is one of the things that we'll be highlighting in volume 3 of this series. So with that said, I would like to thank you for your time and your attention in joining us today. I hope we have many questions to go through, but I also want to take this time to, again, invite you to our upcoming ERA webinars. The next one will be October 2nd, where we explore the unmatched precision of ERA to further maximize patient results. We will be inviting a KOL to a leader using ERA to go through their experience with the ERA test. And then finally, volume 3, which will be November 6th, we're inviting some of our scientific teams and genetic counselors so you can understand how you can better leverage the support that we have to offer to optimize patient outcomes when using ERA. So with that, I will invite Laura back and we will begin our Q&A session.
Yeah, thank you. Thank you very much, Tiffany. Amazing presentation. It was a great opportunity to review the most recent publications. And we can now say that ERA is the only endometrial receptivity test in the market backed by a randomized control trial, so the best evidence. So there is no other test with similar type of scientific evidence. That's really important. And I found really relevant the results on advanced maternal age patients, because we know which is the age of patients typically approaching an IVF treatment for the first time, so they are particularly meaningful. With that said, let's go through the questions, and please, for the audience, continue to write down them. I will review all of them. So, is it very clear that the test is indicated for repeated implantation failure patients, and you have defined perfectly what do we mean for RIF patients? I was wondering if there are other categories of patients who may benefit from the use of the test. So in other words, if we recommend the test for other type of indications, what can you tell us about this?
Sure. So again, the primary indication is recurrent implantation failure, in which we have substantial evidence of the benefit in this patient group. However, there have been other publications showing benefit in other patients. So one prime example are patients with BMIs greater than 30. And this was actually published by the Stanford group in the US. They found that patients with BMIs greater than 30 have a higher risk of a displaced window of implantation. So usually they need additional hours of progesterone exposure. We've also replicated these same findings internally, looking at BMI and association with ERA. So for patients with BMIs greater than 30, ERA could be an indication. There's also been other indications outside of RIF and patients with obese BMI. So with adenomyosis is one example that comes to mind. We could even have seen in our studies perhaps patients with biochemical pregnancy loss. This is very interesting. Back in 2017, we published a paper discussing on further stratification of the original ERA test, where we found optimal receptivity. So essentially, we had the receptive phase. We looked at the clinical outcomes of those patients who transferred within the receptive phase according to ERA. And then we refined the receptive window even further because we found a new subsignature, which we refer to now as late receptive. So these patients need 12 hours less progesterone. So imagine this, they're at the end of the receptive, the window of implantation. And we found that when patients transfer in this late receptive phase, they had a 50% biochemical pregnancy rate, so a significant increase versus optimal receptivity, or maybe perhaps earlier in the window of implantation. So a lot of times I get questions, what about patients with miscarriage or recurring pregnancy loss? Now, recurrent pregnancy loss, I would usually say this is more or less would be applicable to Emma and Alice looking at the microbiome. It may be bacterial pathogens, but we have seen with biochemical pregnancy that this could be an option. So there are other indications. They're not the primary indications of ERA, but there are others in which it could be helpful.
Yeah, thank you very much, Stephanie. And if I'm not wrong, maybe also the endometrial thickness is a factor that may be associated with different window of implantation. I had a look at the abstract that were selected this year at RIF, and we had also an oral communication. So I'm pretty sure that in the future there will be even more indications that we can explore and we can apply to our patients. I have here another. Yeah, sorry.
I should say, yeah, I think that's important because I think the one thing we need to keep in mind with technologies such as ERA, where we leverage transcriptomic analysis, is that this is personalized medicine at its best. So we really have to look at the patient themselves. You know, even sometimes we have patients where maybe they're 40 years old and they only have one autologous euploid embryo left, and maybe not another option to undergo IVF. So in that case, maybe ERA would be a good option. Just we've checked every box to make sure we're really optimizing IVF outcomes as much for our patients.
Absolutely, absolutely. And in this regard, there is another question more related to the protocol that we have to apply specifically to our patients. So can we apply ERA in, for example, a modified natural cycle, or is just for medicated cycles, so HRT cycles?
So ERA can be applied in HRT cycle or natural cycle. And that natural cycle could be modified natural cycle with progesterone supplementation, for example. We just don't want to apply the ERA in stimulated cycles or fresh IVF cycles because this could affect the reproducibility of our findings. So reproducibility is key when doing ERA. And this is in part why the ERA Insight Hub was created, to make sure that we are following the protocol to a T. It seems overwhelming, but it's quite simple. You want to do the exact same thing in the mock cycle as you do in the transfer cycle, with just adjusting transfer time if applicable. So HRT cycle, we recommend just estrogen, progesterone, and you're going to go off the progesterone timing. And then natural cycle, you can do with the HCG trigger or the patient's own LH search. And then, like I said, modified, you can add a supplement with exogenous progesterone. But you just need to make sure you replicate it from cycle to cycle.
Yeah, that's perfect. So in this case, doesn't matter the protocol, you have to replicate really the conditions. I guess also in the endometrial conditions. So for example, not having surgery between the treatment, between the mock and the biopsy cycle, but it's very important to follow all the medications that we gave before the embryo transfer. That's very important. There is another question that is quite related to protocol compliance again, because obviously if we don't follow the protocol properly, maybe we will receive a non-informative or a no results back. So could you please elaborate a little about which type of different non-informative results or no results we have? Which are the causes, the reason behind, apart from protocol compliance, and if you can share with the audience some advices on how to reduce the rates of non-informatives and no results, if they have.
Sure. So fortunately, our non-informative or no result with ERA is quite low globally. So this is the good news. But I would say more commonly we see invalid or insufficient RNA. And what does this mean? Invalid RNA, this is essentially where the RNA degrades and we're not able to get a clear profile for the patient. And the number one cause of this is typically too big of a sample size. So we think, okay, we're taking an endometrial biopsy sample, for example, histology, the more tissue, the better. Okay, it's the opposite here. When we put too much tissue into the ERA cryovial, we overwhelm the RNA stabilizing buffer that we send in that vial, and then the RNA within the tissue is not preserved properly. So then it degrades, and then we get a profile that is not usable, essentially. So my number one advice to avoid invalid RNA is to make sure the sample size is according to protocol. So about maybe the length of 1/3 of the cryovial, which actually, if you've never noticed before, on our cryovials, we have a line towards the bottom, and this gives you an idea of how big of endometrial tissue we need. So you just need, the distance from the bottom to the top, just basically the length of it. Other causes of invalid RNA could be if the sample was exposed to some other fluid besides the RNA stabilizing buffer. So if you are doing a vaginal wash before taking the biopsy, we recommend just saline only and then just cleaning with sterile gauze. You don't want to use iodine or anything else that could potentially degrade the RNA of the tissue if it is contaminated. And then we want to reduce the amount of blood and mucus that we also introduce into cryovial as much as possible. Now, insufficient RNA, that's going to be when there's just not enough tissue, essentially, to perform the analysis. And this could happen if maybe there's a lot of blood and mucus and it looks like there's sufficient tissue in the cryo, in your pipelle and then in the cryo tube. But if it's mostly consisting of blood and mucus, this can lead to insufficient RNA. And then lastly, non-informative. This is in less than 1% of the cases we receive. Basically, the transcriptomic profile that we obtained does not match any within our controls for the test. And as I said, this happens very rarely. And the good news is that in over 95% of rebiopsies, we're able to get a valid result the next time. And why this is good, it means that it's something cycle specific why we got that non-informative result, not patient specific. So just because you get a non-informative result does not mean that the patient can never get information about her window of implantation. And when this happens, we'll reach out, we ask, okay, is there anything difficult about this biopsy? Did the patient have any endometrial bleeding during her ERA mock cycle? We know that endometrial bleeding is associated with non-informative result. So for this reason, we ask that you do no longer than 17 days of estradiol priming before introducing progesterone, because this extended estradiol protocol could lead to endometrial breakthrough bleeding, which again is associated with non-informative results. So that is my advice there. Not too big of a sample. Follow the protocol, 1/3 the length of the cryovial, reduce blood and mucus, and no more than 17 days of estradiol priming prior to start of progesterone.
Okay, thank you. Thank you very much for specifying all the results. We have one more question related to the protocol. The question in details is asking if in the modified natural cycle, we have some sort of recommendation in terms of what luteal phase support we can have. So do we recommend something specifically for supporting the luteal phase?
Do you mean, what are you referring to specifically? Or did they mention?
No, it's not mentioned. I think it's referred to supplementation hormones during the luteal phase. I mean, if we have recommendation in terms of one brand or the other, one type or the other, one dosage or the other.
No, I mean it's completely up to the clinician of how they want of what medications they want to give, what dosage, what administration type. Sometimes I get questions like, is vaginal progesterone better than IM progesterone? And I know this is quite regionally specific. So for example, in the US here, we tend to do like a mixed protocol with IM progesterone and vaginal. Whereas in other countries, I'll see maybe more vaginal progesterone be used. But there's not one specific protocol or administration type or anything that we recommend. The best thing, for example, let's take an HRT cycle, is just to use estrogen and progesterone. When we add in other medication, it could complicate because again, we need to make sure that everything is reproducible. So if you were to give, say, a steroid in the transfer cycle, you want to make sure you give the same steroid in the mock cycle. But as far as dosage or medication type in any cycle, whether it be modified natural or HRT, it's completely up to the clinician. And all we just ask is that you replicate it and then you also control endogenous progesterone. That's super important. We want to make sure we're controlling endogenous progesterone by making sure we're measuring it within 24 hours prior to the first intake of exogenous progesterone HRT cycle, or day of HCG trigger in, say, a modified or in a natural cycle with HCG trigger, just to make sure we haven't had a premature progesterone rise, which could affect reproducibility of the results. Other than that, no gonadotropins or ovarian stimulation, but it's up to the physician on their actual protocol they use.
Okay, thank you very much. That's very clear. So if we don't have more questions, I think we can close the session. So Tiffany, I want to thank you again for this brilliant presentation. I want to thank all the participants. Thank you very much for joining us. And I also want to remind you to register for Volume 2 and Volume 3 to continue the story on ERA. So thank you very much again.
Thank you.